During this section, we're going to talk about treatment of C. difficile infection, and it can become confusing given the multiple options that we have to treat C. difficile. So this is a menu of the options that we have available to us. We have metronidazole, vancomycin, fidaxomicin, bezlotuximab, surgery, and fecal microbiota transplantation. Probably the best place to start to consider the treatment algorithm for C. difficile are the guidelines. And what I'm presenting in this slide are the Infectious Disease Society of America guidelines from 2010. Within those guidelines, it was recommended that we triage patients based upon the severity of their infection, with severe infection being defined as a white cell count greater than 15,000 or a creatinine greater than 1.5 times the patient's baseline. For initial non-severe infection, it was recommended that patients receive 10 to 14 days of metronidazole 500 milligrams 3 times daily. For initial severe infection, vancomycin 125 milligrams 4 times daily was recommended to be given for 10 to 14 days. For initial severe complicated infection defined by hypotension, shock, ileus, or megacolon, it was recommended that patients receive everything we have. Basically, vancomycin 500 milligrams 4 times daily, intravenous metronidazole 500 milligrams 3 times daily, as well as vancomycin per rectum. For the first recurrence, it was recommended to reuse the same antimicrobial used for the treatment of the initial infection. And for subsequent recurrences, it was recommended to use vancomycin in a pulsed or tapered regimen. But this is now dated, with quite a bit of new literature and new options available to us. This was updated in the 2017 update to the Infectious Disease Society of America guidelines that were actually published in February of 2018. Within these guidelines, it was recommended that we triage patients similarly using a white blood cell count greater than 15,000 or a creatinine greater than 1.5 milligrams per deciliter to define severe infection. With those patients with initial infection that was non-severe, we will notice that metronidazole has been largely removed. It is now recommended that we use either vancomycin 125 milligrams 4 times daily for 10 days or fidaxomicin 200 milligrams twice daily for 10 days. For those patients that do not have availability to vancomycin or fidaxomicin, it is now recommended that metronidazole be used. For initial severe infection, only vancomycin or fidaxomicin are recommended. For initial severe complicated infection, or the so-called fulminant classification, patients were to receive the same treatment as was recommended in 2010: intravenous metronidazole, oral vancomycin, and vancomycin per rectum. For the first recurrence, the guidelines have changed significantly. It is no longer recommended to reuse the same antimicrobial used for treatment of initial infection. We are to choose from giving the patient either vancomycin 125 milligrams 4 times daily for 10 days, vancomycin in a pulsed and or tapered regimen, or fidaxomicin 200 milligrams twice daily for 10 days. For 2 recurrences and beyond, it is now recommended that we either give a vancomycin taper or a standard vancomycin course followed by a rifaximin chaser or fidaxomicin, or finally, for patients that have received 3 or more antimicrobial courses, consideration should be made for a fecal microbiota transplantation. Within the subsequent sections, we will go into some of the literature that drove these changes to the guidelines so that we have a better understanding of why these changes are made and why certain patients would benefit from specific treatments.